Hi, my name is Dr. Kushal, and I'm here to take a session on hyperkalemia and ECG. Before I start, I want to thank StudyMEDIC and its organizers to give me this opportunity to take this session. Very important session, very basic session. As an emergency physician, we all have seen this condition, and we have all have treated this condition almost every day on a clinical basis. So potassium is one of the most important component of the body. Why potassium matters? Because it plays a very important role, a crucial role in maintaining the physiological functions of the body, like nerve conduction, muscle contraction, cardiac activities, um, maintaining the homeostasis of the body. Okay. 98% of the potassium is present in the cell. That is, it is mainly an intracellular cation, and only 2% is present outside the cell. So the serum potassium, what we measure in the lab, is roughly 3.5 to 5.3 milliequivalents per liter. And this is a component of extracellular space or extracellular component. Okay. So, what is it that keeps the potassium inside the cell? There is something called as sodium potassium exchanger. So, what happens is this exchanger keeps the potassium inside the cell and the sodium outside the cell with the help of some energy or ATP. Okay. This potassium, higher potassium inside the cell and lesser potassium outside the cell creates a potential difference, a gradient, which is called as membrane potential. This membrane potential is very important. This gradient is very important for the excitable cells like cardiac and nerves to maintain its normal activity. What are the causes of hyperkalemia? The list is long and tiring, but grossly it is divided into three main causes. One is when there is an increase in oral intake, like potassium, high potassium containing food like banana, spinach, and other things. This kind of increased oral intake changes are only seen in a renal failure patients. A normal patient having banana doesn't end up in ED. Okay. The second cause is the conditions which shifts the potassium inside outside of the cell from inside. That is extracellular increase in the extracellular potassium. This can occur in rhabdomyolysis, hemolysis, tumor syndrome, sepsis, metabolic acidosis. And the third condition is called occurs when there is a decrease in excretion of potassium. This occurs when there is a renal failure. Now, why is it this membrane potential very important? Because what happens is, as you can see in this chart, in this graph, the bottom line, the straight line is called as resting membrane potential. And the second line next to the bottom line is called as threshold potential. So usually whenever the action potential reaches the cell is usually in the resting membrane potential, which is usually minus for nervous system, it is minus 70. For cardiac cell, it is minus 90. So this RMP, whenever an action potential reaches that particular kind of cell, the sodium channel opens up and the cell becomes slightly positive. Whenever it becomes positive and it reaches the threshold potential, the action potential is generated on its own. Okay. And then comes the end of the action potential, which is called as repolarization or hyperrepolarization. This occurs because of potassium. Now, the cell again is back after the hyperrepolarization. The cell again is back to the resting membrane potential because of the potassium or because of the sodium potassium exchanger, what we have seen before. Okay, now whenever there is an increase in extracellular potassium, what happens is the cell itself becomes partially depolarized. That means the resting membrane potential becomes more positive, like the green thing what you're seeing, no? It becomes slightly positive, and this becomes the new resting membrane potential. So it is very easier for this particular kind of cell to reach to the depolarization or the threshold potential. Okay, and that is why you are going to see more excitability in such kind of cardiac and nervous cells. So that's why the patient presents usually with some kind of arrhythmia or ECG changes in hyperkalemia. Okay, so ECG changes, we have seen that on the clinical basis, we have seen that usually the ECG changes are not related to the potassium levels clinically. Yes, but theoretically, what they have seen, what they have told is ECG changes can be seen when the potassium is more than 6.5 millimole per liter. So again, the hyperkalemia is divided into mild, moderate, severe risk. Uh, but the high risk hyperkalemia is usually defined as the presence of pathological ECG changes with potassium of greater than 6.5 millimole per liter. What are the ECG changes we see? We see pre-R prolongation, we see flattened P waves, we see sinusoidal wave or sine wave pattern. We see ventricular VT, ventricular tachycardia. We see ventricular fibrillation. We see asystole in severe hyperkalemic patient. Okay, so treatment-wise, there are three main treatments whenever such kind of patient comes to you in emergency. The first kind of treatment is something called as cardiac stabilizing agent. The second one is called as potassium lowering agent. And the third one is called as potassium excreting agent. So let's see quick one by one. What are cardiac stabilizing agent? It's calcium gluconate. It's the calcium. Okay. Please remember that calcium doesn't lower the potassium. Okay. In fact, it stabilizes the cell membrane, raising the threshold potential. Okay. Reducing the risk of arrhythmias. Very important. Usually there are two kinds of calcium we know. One is called as calcium chloride, one is called as calcium gluconate. We prefer calcium gluconate because it is less venous irritating. Calcium chloride is very irritating to the veins. Okay, that's why calcium gluconate is preferred. Calcium starts affecting within 2 to 5 minutes. The peak of action is usually seen within 30 minutes. Okay, and the calcium acts till 60 minutes. Please remember, calcium is not given in all hyperkalemic patients. It is only given when there is an high risk ECG changes seen in hyperkalemia. So calcium should not be given for mild hyperkalemia. Okay. Also, you should avoid mixing calcium with bicarbonate because it has a precipitation risk in the IV line. Next comes potassium lowering agents. What are the potassium lowering agents? Which lowers the potassium, lowers the extracellular potassium or serum potassium. How does it do? It usually acts on sodium potassium ATPase and shift the potassium from extracellular space to the intracellular space or inside the cell. So those are beta mimetics and insulin. Okay. Beta mimetics, usually we start with nebulized form, nebulized salbutamol. It can be given as 10 to 20 mg. Okay. And this reduction occurs usually at 90 minutes. We have seen that so potassium reduced by 1.19 to 1.29 millimole per liter. Insulin also acts on the same mechanism, sodium potassium ATPase, which shifts the potassium inside the cell. Insulin acts in another way also, which is called as GLUT or glucose transporter type. So what happens is insulin pushes the glucose into the muscle cells or inside the cell, okay, resulting in reduction in the insulin, serum insulin level. And this shift from glucose, this shift of glucose from extracellular to intracellular space will take potassium along with the glucose inside the cell. Okay, so insulin reduces the serum potassium levels as well. Okay, we use IV insulin, usually acts within 15 minutes with maximum effect of 30 to 60 minutes. One of the very important side effect of this insulin is hypoglycemia. So patients who are present with normoglycemia, and when you are trying to give insulin, please mix dextrose at least 25% or 50 grams along with the insulin so that patient doesn't become hypoglycemic. Okay. The next is sodium bicarbonate. Sodium bicarbonate per se theoretically doesn't reduce the potassium levels as such, but the studies have found out that when you mix it with insulin, dextrose, and bicarbonate, it reduces the potassium by 60 minutes. Okay. Sodium bicarbonate is usually not preferred, not given in all hyperkalemic patients. In fact, it is given in only in the patients only with severe metabolic acidosis and the patient having normovolemia. Okay. Why normovolemia? Because sodium bicarbonate is an hypertonic fluid. It will cause volume overload. It will cause hypernatremia. It will cause metabolic alkalosis. Okay. Though such kind of studies in ED are lacking, theoretically, it does, if you give in large amount, it does cause volume overload. Okay. Um, loop diuretics. Loop diuretics, according to the kidney outcome guidelines, loop diuretic uh, may help hyperkalemic patients in the patients who are volume overload. That means patient has come to us with pulmonary edema or volume overload status. You can give loop diuretics if there is no AKI present. Okay, this tends to reduce the potassium in the body. However, there is no prospective clinical trials that are done to detect the efficacy of hyperkalemia. Sorry, efficacy of diuretics in hyperkalemia. Okay. Next comes something called as sodium polyester sulfonate. Or K binder, if you hear in clinical terms in your ED. So previously, for 50 years, the SPS, that is called as sodium polyester sulfonate, has been the main treatment for hyperkalemia. So what it does is it used to throw the potassium through GI losses. But few reports have shown that it can cause colonic or intestinal necrosis. So right now in ED settings, and SPS is not recommended. In fact, there has been a compound that replaced the SPS, which is called as sodium zirconium cyclosilicate, SZC. Okay, this has been very effective in the setting of ED. The efficacy is exactly like SPS without the side effects of colonic necrosis. Okay, and the last one is called as renal replacement therapy. So there is a mnemonic we usually use called AEIOU. There are five main indications of starting RRT. One is acidosis, electrolyte imbalance or disbalance. This electrolyte disbalance is mainly refractive hyperkalemia. So you have tried all the things what I've discussed till now, and still the potassium is more than 6.5 with or without ECG changes, you have to start RRT. Okay. Otherwise, the other indications are intoxications, which in fact patient is intoxicated with dialysable drugs, overload, volume overload status, uremia, uremic symptoms like encephalopathy, pericarditis, bleeding, nausea, vomiting. Okay. So this is the summary of what we have talked till now. There are three associations what this chart tells us. The first one is called as UK Kidney Association. The second one is European Society of Cardiology, and the third one is kidney disease improving global outcomes. Okay, each has its own recommendation, but grossly remains the same. We start as from the cardio stabilizing agent, then we go to the insulin lowering, potassium lowering agents. Then we use sodium bicarbonate only in the cases where the pH is severely acidotic, less than 7.2. Okay, the European guidelines even doesn't recommend sodium bicarbonate at all. Diuretics also is only recommended when there is, a chronic hyperkalemia or kind of fluid overload status. Okay, oral potassium binders or K binders, which we have discussed, we can give SCZ 10 grams 3 times a day for roughly 72 hours to reduce the potassium. Hemodialysis is the last option, is usually done after seeking experts' advice that why potassium is not coming down to its normal limit in spite of all the treatment. So a quick summary: whenever a patient comes to you with hyperkalemia with typical ECG changes, the first thing what you do is to protect the heart, cardiac stabilizing agent. You give calcium gluconate 10%, 30 ml over 10 minutes. Repeat after 5 minutes again if the ECG changes are still persistent. Okay. Then comes your shifting or potassium lowering agents, which is mainly shifting the potassium intracellularly, that is insulin glucose. We give 10 international unit of insulin with 25 grams of glucose or 50 grams of glucose according to the glucose concentration. Okay, we give salbutamol as a nebulization agent, 10 to 20 mg inhalational, and bicarbonate only if the patient is severely acidotic. Okay. Next comes the excretion of potassium. Oral potassium binders, as we have spoken, we have to give the oral potassium binders. Diuretics only in the cases when the patients are in hypervolemic status, and the hemodialysis only after consideration with expert or nephrology opinion. Okay, so this is how we treat it. We treat the hyperkalemia with the ECG changes. I think we come to an end with our session. If you have any doubts, please ping me. My number is all with you guys. I wish you all the best. Thank you.